All right, it's now 5:35. I think we can start. Okay, before we start, Tawanda, if you can hear me, please confirm if my audio output is okay. And please also confirm if you can see my screen.
Hello, Doc. Yes, we can hear you clearly and I can see your screen from here.
Okay, thank you. So we can start. Okay, good evening once again, dear colleagues. My name is Dr. James Nindi. I qualified at the University of Zimbabwe in 2018. Currently, I'm in private practice, working as a family dentist. And today I'm going to be taking you through the second session of principles of adhesion and composites. And today in particular, we're going to discuss principles of dental composites. Okay. So before we start, we're just going to touch on a bit of what we discussed last week. So this is just one slide, which basically shows us where we are currently with regards to adhesive dentistry. So the key is to your right, and what we're working with is to your left. Currently, we're working with adhesive systems with prime, bond, and dental composites. And the whole idea is to be able to occupy as much space as possible so that the composite can come close to the tooth and be able to minimize problems like formation of gaps, which will lead to postoperative sensitivity and other issues like that. And also last week, we discussed that the primers which are in the bond come in two types. We have ethanol-based solvents and water-based solvents. So the difference between the two will determine whether or not you're going to do what is known as wet bonding or dry bonding. If you're using a bonding system which is ethanol-based, it means you have to use wet bonding because ethanol-based solvents have water-chasing properties. So you can afford to leave the dentine a bit dry and visibly moist. There are various ways of doing it. You can put a cotton pellet in the cavity prep and dry so as not to blood dry it. If you're using water-based solvents, you can blood dry the tooth structure because water-based solvents functions that re-expand the class collagen fibrils from drying. So that is the difference between the two. And then we also classified adhesive systems because currently there are three ways of classifying adhesive systems, which are classified by the number of clinical steps, classification by etching method, and classification by generations. All of these classifications use the same modalities of etch, priming, and bonding. And at the end of the last lecture, we summarized everything by 2 points. Basically, you need to know the adhesive system that you're using. You need to know the components which will determine whether or not you're going to do wet bonding. Below is a table which combines all three classifications by number of steps, etch modality, and generations. So by mastering this slide, you can be able to take any adhesive that you get from anywhere on the market and be able to depict how you can be able to use them. Because knowledge of a particular dental material that you have will be able to save a number of problems in usage. Because by knowing that you're using a 4th generation, you will know that you have to etch and rinse, and that you have a separate etching step. If you're using 8th generation universal, you know that it's a self-etching modality, but according to what we described last week, you can use this in etch and rinse modality as well. Now, moving forward, today we're going to discuss about composites. What you're seeing on the screen is basically the outline of this lecture. We're going to define composites, outline the components of a dental composite, classify dental composites, talk a bit about polymerization shrinkage, and then make a summary at the end. Now, to start off, composites are basically a mixture of two materials whose properties are superior to the separate materials, right? And the components are the ones listed there. We have a resin matrix, we have a filler, we have a coupling agent which joins the matrix and the filler together. We have curing initiators, and we have colorants. These colorants determine whether or not you're going to have your A1s, A2s, A3s, or A3.5. Now, there are various ways of classifying dental composites. You can classify them according to viscosity, you can classify them according to the type of resin, or you can classify them according to the type of filler. Now, according to various studies and according to how composites have evolved, because of the major influence of the fillers on the physical properties of dental composites, the frequently used classification of dental composites is based on the type and the particle size of the reinforcing fillers. And this classification is what we're going to use in this discussion. Now, there are various types of fillers and there are various ways of classifying composites according to the filler content. We have your macrofill composites, microfill composites, and the hybrid composites. And we're just going to discuss each as we go along. Now, to start off, we have macrofill composites. Now, these macrofill composites were developed in the 1960s. These contain the largest filler particles, with filler content being as much as 70 to 80% of the total weight of the composite. Now, it being 80% of the total weight, this meant that they have great strength, and hence they were mainly used for posterior restorations. But however, they're no longer used because they have a rough surface, which leads to plaque accumulation and staining. Now, the reason why these composites have a rough surface is because of the high percentage of filler content. So because of this major disadvantage, these macrofill composites are no longer in use, and I don't even know if they're still on the market. And then came in the 1980s, scientists discovered the microfilled composites. These composites contain the smallest filler particles, with the filler content being 40 to 50% of the total weight of the composite. So it being 50% of the total weight, this meant that they have a high polishability and a great finish. Hence, they were primarily used in anterior restorations because of aesthetics and smoothness. However, they're no longer used because of low strain. And the reason why these composites have low strain is because of the low percentage of filler content. And because of this major disadvantage, these microfill composites are no longer used. Now, scientists continued research, and in the late 1980s, they came up with the hybrid composites. Now, these composites are called hybrid because the filler particles are of mixed sizes. The filler particles contribute 75 to 80% of the total weight of the composite. And because of this large percentage and mixed range of filler particles, they have properties of both macrofill and microfill composites, meaning that they're as strong as macrofill composites and they polish as good as microfill composites. So they have a better surface finish and can be polished smoother than macrofill composites, and they have greater strength and wear resistance than microfill composites. So because of these superior properties of having a combined strength of both microfill and microfill composites, these hybrid composites are the most commonly used currently and the most common on the market. Now, scientists went on to continue their research, and then they discovered that there can be various ways of producing these hybrid composites. So you have various types of hybrid composites. You have your conventional hybrid, macro hybrid composites, micro hybrid, and your nano hybrid composites. So after talking a bit about the types of composite, the question now is, which is the best composites for either anterior or posterior restorations? So to be able to answer that question, we first need to understand what polymerization shrinkage is, because it's a major problem in composites. Now, composites have a major advantage of being aesthetic and tooth-like. It's one of the main reasons why composites came into the market, came into the picture to replace amalgams. But however, in as much as composites have a major advantage of being aesthetic and tooth-like, they have a major disadvantage of having polymerization shrinkage, as you can see on the picture there. Now, the question is, what is polymerization shrinkage? So polymerization shrinkage is the change in volume of the dental content material after you cure it. So this change in volume happens because composite is a resin and it contains monomers. So this change in volume results in the formation of a gap between the composite and the restoration margin, which will lead to issues like post-op sensitivity, secondary caries, structure of restorations, to mention but a few, etc., etc. Now, before we move on, there's this slide that we have here. So this is a shrinkage stress diagram, which depicts the various composites that we have and the various percentages at which they shrink at, okay? And then this is the diagram which we used in last lecture, which depicts the various generations that we have of the adhesive systems with all modalities put into one. Classification according to age, classification according to number of steps, and classification according to generations. Now, for this to be clear, I'm going to use a common example which you use probably on a daily basis. Let's say we take a common composite on the market, which is tetric evoceram, which is there on the diagram there. Now, when you place tetric evoceram in a cavity prep, and when you cure it, it will shrink, the volume of that composite will shrink by 2%. And that shrinkage will generate a stress of 6 megapascals. So let's say underneath this composite, you've used a universal adhesive, which is Scotch-Bond universal, a common one on the market today. If you use this adhesive, this bond, right, the shear bond strength that it will offer is over 30 megapascals. Now, if you look at this, if you use an adhesive which has a shear bond strength of over 30, yet the composite that you've used generates a stress of 6 megapascals, it means that the adhesive will be strong. For this to be clear, let's say you've used a first generation, which I don't think is on the market now. If you use a first generation adhesive system, it will offer you a shear bond strength of only 2 megapascals. And if you go on to use this tetric evoserum, which generates a stress of 6 megapascals, it means that when this composite cures, this composite then shrinks, it will generate a stress of 6 megapascals, which is more than the adhesive that you have used of 2 megapascals. So it's very important to be able to know the material that we use and be able to use a composite which generates a stress which is as low as possible, and be able to use an adhesive which generates a stress or a shear bond strength which is as high as possible. So in this case, if you use tetric evoserum on top of Scotch-Bond universal, because of this major big difference, there won't be any adhesive failure, and that adhesion will be very strong. So I hope this was clear. This makes sense, because this will cover a lot of issues, especially in our clinical practices. If there are any questions, we can be able to try and address them at the end. Now, moving on, because polymerization shrinkage is a major problem, we need to find strategies to be able to overcome this. And as far as research is, I managed to find 2 ways on which you can be able to overcome polymerization shrinkage according to the current literature. The first one being the placement of composite. So placement of composite is based on a concept known as C factor. So basically, C factor is a ratio of bonded surfaces to unbonded surfaces. So C factor is proportional to the shrinkage stress, or C factor is proportional to polymerization shrinkage. So to reduce shrinkage stress, we need to reduce the C factor, which simply means we either need to reduce the number of bonded surfaces or increase the number of unbonded surfaces. So this is achieved by the oblique increment technique, which is depicted on picture B. The oblique increment technique is based on the fact that the C factor determines the shrinkage stress. So if you look on the picture there, on part A, let's say you put the first increment. Now the C factor, to determine the C factor of this increment, we have to calculate the number of bonded surfaces. So this picture is a 2-dimensional representation of a tooth which is 3-dimensional. So the number of bonded surfaces is not 3, but it's actually 5, because we have one which is facing the screen and we have one which is behind the screen. I hope this is clear. So if we consider that, it means the number of bonded surfaces is 5 and the number of unbonded surfaces is 1, making the C factor to be 5. If we then employ the oblique increment technique, which we said can actually help in reducing the polymerization shrinkage. If we go on to part B of the picture, if we go on the first increment, the number of bonded surfaces will be 4, because we have 2 here and 1 in the picture, 1 behind the picture, and then the number of unbonded surfaces is 1, making a C factor of 4, right? So in as much as this might seem insignificant, but this can actually contribute to reducing polymerization shrinkage. So basically what we're saying here on this slide, we're saying a technique which can be used to reduce polymerization shrinkage in composites, we have to employ the oblique increment technique. And the second way of reducing polymerization shrinkage is taking into consideration how composite cures. So we're going to talk a bit about how composite cures before we go on to talk about how we can reduce polymerization shrinkage. Now, generally, there are various types of composites. The most common ones, which are the light cure composites, which we mainly use in our clinical practices. Now, the dental composite, if you remember in the first slides of this lecture, I said composites contain the resin matrix, the filler, the coupling agent, colorants, and curing initiators. So the curing initiators that we find in the composite that we use, the main one is camphorquinone. And this camphorquinone curing initiator is specifically sensitive to light with wavelengths which fall between 400 and 500 nanometers. So this range of wavelengths corresponds to the blue light, which we have in our clinical practices. So what we're saying is when the blue light engages the camphorquinone curing initiators, free radicals are formed. And these free radicals give energy to the monomers in the composite to turn into polymers. And this will result in the hardening of the composite. So for this to work, the blue light has to be at a certain intensity for optimum results. If you check your light cures, you can be able to see this. The SI unit for intensity is milliwatts per square centimeter, and the range of intensity for curing dental composite is around 300 milliwatts per square centimeter. Now, moving on, we need to understand what the gel point is now that we understand how composite cures. When composite cures, it goes through two phases, the pre-gel phase and the post-gel phase. When you put the composite in the cavity preparation and start curing it, it moves from the viscous state to the solid state. So as you cure it, it becomes more viscous and ends up hardening to the point where you can't mold it anymore. This point where you can't mold it is called the gel point. So the gel point is a stage where the composite can no longer flow. It's basically a point where the composite is now hard. And at this point, the composite material can no longer adapt to the stress. Now moving on. As we said, there are two phases in the curing of the composite, the pre-gel phase and the post-gel phase. The pre-gel phase is the initial stage of curing and the composite will still be in the viscous state. So the slower the transition from the pre-gel phase to the post-gel phase, the lesser the shrinkage stress, because the material can absorb the stress and the stress will not be transferred to the tooth, right? So trying to illustrate the diagram, we're saying in the pre-gel phase, dental composites have the ability to absorb the stress, resulting in the stress not being transferred to the tooth, right? So the aim of this strategy, the take-home message is, we want to extend the pre-gel phase for as long as possible, thus delaying the gel point. And how we do that, our light cures have settings where you may have the soft start. Because if you use the soft start, the intensity that you'll be using, the intensity that will be going is enough to be able to extend the pre-gel phase of the composite, thus allowing us to be able to minimize polymerization shrinkage. Again, I hope this was clear. If there are any questions, we can be able to address them at the end. So, summarizing strategies to overcome polymerization shrinkage. In placement of the composite, because of the speed factor, we can overcome polymerization shrinkage by using oblique increments of the composite. And with regards to curing of the composite, we can try to overcome polymerization shrinkage by employing the soft start setting in our light cures. Now that we've discussed polymerization shrinkage, we go back to our question: which is the best composite for anterior or posterior restorations? Now we're going to go through a few studies to be able to answer this question. Firstly, this is a clinical study, which was basically clinical evaluation of class 4 cavities, which were restored by two composites, nanofill composite and nanohybrid composites. This was done in 2018. And after the study, they basically realized that there are no statistically significant differences between nanofill and nanohybrid composite restorations. Basically, we're saying that the efficacy between the two is actually comparable, meaning to say you can actually choose whether to use a nanofilled composite or a nanohybrid composite in class 4 cavities. These are anterior restorations. Moving on, this is a systematic review whereby nanofill or nanohybrid composite were compared to traditional microhybrid composite in posterior restorations. And basically it was found that in the posterior area, nanofilled and nanohybrid composite are capable of satisfactory clinical effectiveness, which is similar to that of macrohybrid composite. Meaning to say that the choice of the restorative material between nanofold, nanohybrid, and microhybrid composite continues to be up to the clinician performing the restoration. Meaning to say that in the posterior area, in, for example, a class 1 restoration, if you have a choice, you can choose between nanofold, nanohybrid composite or microhybrid composite, because both of them have satisfactory clinical effectiveness. Lastly, there's another clinical study which was done in 2017, whereby they compared microhybrid composite and nanofill composite in occlusal cavities over a period of 5 years, using the 3-step etch and rinse modality. And it was found that after 5 years, none of the microhybrid or the nanofill composites failed, and the success rate was 100% for both composite materials. So, which is the best composite for anterior posterior restorations? These are your options. You have your microhybrid, nanofill, nanohybrid. For the microhybrid, we have your Filtech Z250. Personally, I've never used it. I don't have experience in using Filtech materials, but I've used T-Econom Plus materials, and they're good in both anterior and posterior restorations. You have your nanofill modalities, which are your Filtech Supreme XTs, and you have your nanohybrids, which are your Ivoclar products, which includes Empress Direct, Tetric Evoserum, and Tetric N Serum. I think these are the most common ones which are on the market. So because these composites can be used in both anterior and posterior restorations, they're also known as universal composites. Now, moving on, scientists continued their research to try and improve composites. They discovered a problem. The composites that were mainly used are hybrids, and they contain 70 to 80% filler content. So because of this high filler content, it meant that they are less translucent, thus allowing less light to pass through. This means that when placing these composites in cavity preparation, the maximum thickness of increments shouldn't exceed 2 millimeters for adequate depth of cure because of the high filler content, right? So this resulted in a lot of time consumption in placing composite, because imagine you have a big class 1 cavity. So as to make sure that you have an adequate depth of cure, you shouldn't put increments which are more than 2 millimeters. So this means you take a lot of time in doing a simple class 1 restoration. So this weakness prompted a lot of research to be done to find a new composite where this problem of multiple increments is reduced. So in came the bulk fill composites, which are there in the picture there. So basically, bulk fill composites were manufactured to solve the problem of multiple increments. They have less filler content, and this less filler content meant more translucency, meaning that more light can penetrate the composite, meaning that you can put increments which go up to 4 millimeters. So this means that they can be placed in large increments, thus reducing clinical time. However, the main issue with these bulk fill composites is because they have less filler content, meaning less physical characteristics with regards to aesthetics, right? So to overcome this issue of bulk fill composites having less filler content, studies were done, and they suggested and advised that all bulk fill materials can be capped with conventional resin-based composites to improve their aesthetics and physical properties. Meaning that, for example, if you're doing a class 1 restoration, which is quite big, you can fill the base with the bulk fill composite, and then on top, you can put the nanohybrid composite, the nanofill, or the microhybrid to enhance the physical properties of the overall restoration. Because if you only fill with the bulk fill composite, because it has less filler content, the bulk fill will have less physical properties, and the wear and tear will be more than when you put the conventional resin-based composite, which are your nanohybrids, on top to enhance the physical properties of the overall composite. Okay. And then lastly, we're going to talk about flowable composites. Basically, flowable composites have the same composition as conventional composites. They contain 20 to 25% less filler content, making them less rigid. Now, before we end, I'm going to talk a bit about the oxygen-inhibited layer. Now, as I spoke before about the curing of composites, free radicals are formed. When you cure the composite, free radicals are formed, and they have a greater affinity to oxygen than to the monomers in composite. So this means that when you're placing your composite, the topmost layer of every composite placement is not polymerized because it is exposed to oxygen, and this oxygen will scavenge the free radicals, resulting in the topmost layer becoming uncured. So this oxygen layer is good for the bottom layers, nonetheless, because it helps in bonding to the subsequent layers. So imagine this: when you're placing your composite, let's say in a class 1 restoration, the topmost layer of that composite is uncured, right? It being uncured, if you put another increment of composite on top of that layer, there'll be bonding that occurs, right? Because the double bonds will be exposed. But then at the very end, at the very top, the oxygen inhibited layer is uncured and it remains soft. But this is the topmost 10 micrometers, which is very minimal. And this is very important to take into consideration, especially in anterior restorations, because the fact that we're saying that this oxygen inhibited layer is uncured, it means that it will remain soft. And it being soft, it will become sticky and will end up with issues like staining and plaque accumulation, etc., etc. So it's very important for us to find ways and means to minimize this oxygen inhibited layer. So there are two ways in which you can minimize this. The first one is to cure the composite through glycerin gel. Basically, how you do this, when you're done with your restoration, you apply glycerin gel and then you cure. Because by applying this gel will act as a barrier to prevent the scavenging of free radicals by the oxygen. Another way in which you reduce the oxygen inhibited layer is the most common way, which I believe most of us practice, is whereby you finish and polish the composite. So the main idea here is that you'll be removing the topmost 10 micrometers of uncured composite, so that at least you won't have issues like plaque accumulation and staining. Okay, so that's it about the oxygen inhibited layer. And that being said, this is basically the summary of everything that we have discussed from last week to today. With regards to adhesion, basically, it's important to know which adhesive system you'll be using. It will guide you to be able to minimize any problems that you may face. And with regards to composites, basically, we said composites are a mixture of two materials, which are your resin and your fillers. Filler particles determine physical properties. Hybrid composites, the filler particles of various sizes, make them the most superior and the most used currently. The best composites for anterior posterior restorations are your microhybrids, nanofills, or nanohybrids. And because you can be able to use them in anterior and posterior sections, they're also known as universal composites. We have a major issue with composites. This issue is polymerization shrinkage. This can be reduced in two ways: using oblique increments, placing your composite in the cavity preparations, and also soft start curing by applying this setting in your light cures. And then lastly, the oxygen inhibited layer is something to take into consideration, and this can be minimized by either curing the topmost layer with glycerin gel application or finishing and polishing the composite. So that said, we've come to the end of this session. Thank you very much. Over to you, Tawanda. If there are any questions, we can try to address them before we end the session. Thank you.
Good evening. Thank you for that lecture, Dr. Indy. That was great. I don't know, colleagues, if there are any questions. So, Dr. Nindi, I've got a question. Under the reduction of polymerization shrinkage, you mentioned the oblique increment, which is fine. You mentioned something to do with soft start curing. Is there a specific curing light which does this? For the second method?
All right. Apparently, I'm sure all curing lights have this setting. So if I'm not mistaken, all curing lights have three settings. You have one for the oscillating, right? Which is basically on, off. And then one which is timed curing, which basically increases and then maintains a certain intensity and then increases again. And then lastly, you have the soft start, whereby over the 15 seconds that you'll be curing, it will be increasing intensity as you're going. So I'm sure all of the light cures that I've used in all the practices that I've worked for have this setting. So I'm sure if you go through the manual of the particular light cure that you have, you can be able to find the setting for the soft start.
All right. Yes. Okay. Well, now that you've mentioned it, I think I've got it. And then there's the second thing you said, reduction of the oxygen inhibition layer. You mentioned the gel. Is it a specific gel you get from somewhere, or I'm just interested to know the one you said you can cure through that? Okay.
According to the research that I did, it can be any glycerin gel, so long as it's glycerin, because the main thing that we want to achieve is to be able to prevent the oxygen from scavenging the free radicals in the composite. So the whole idea is to cover the composite. So according to the research that I did, you can do this with glycerin gel. It can be any glycerin gel, so long as it's glycerin.
Also any glycerin.
Yes.
Okay, great. Okay, are there any other questions, colleagues? I'll also check the chat. So we just have a comment, good teaching from Dr. Msia. Thank you, Doc. Are there any other questions? Okay, if there are no questions, I'd like to say on behalf of the Professional Development Committee, thank you, Dr. Nindi, for this great lecture, which has come in a two-part series. We hope to hear from you again, very informative and educative. If there's nothing from anyone, would like to say good evening and see you again at the next lecture. Thank you, Doc.
All right. Thank you very much, Dr. Vicky. Thank you to all. Enjoy the rest of the evening.
Same to you. Bye.